Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record. Please also remember to pick up, fill out, and return the program evaluation. And if you could give the CME committee any ideas in regards to future topics or future speakers, we would be very appreciative. Today, it's my pleasure to introduce Dr. Jessica Smith. Dr. Smith did her, or attended medical school at the University of California, Davis, and then did her general surgery residency at the University of New Mexico before doing a fellowship in minimally invasive and bariatric surgery at the University of California, San Francisco. Currently, she is clinical associate professor of GI, minimally invasive and bariatric surgery at the University of Iowa, where she also is the medical director of the bariatric surgery program, and she kindly has accepted our invitation today to join us and provide us with an update on bariatric surgery. And please join me in welcoming Dr. Jessica Smith.
Thanks. Thanks, everybody. Everybody can hear me okay? Yeah? Okay. Well, thank you so much for inviting me, and I tried to make a very broad presentation because I think we have a pretty diverse audience. So, and then I'll be sure and leave enough time for questions at the end. If there's something that I don't cover that you're very curious about, please feel free to ask. A lot of this will not be news to you, but I think we'll use it as a segue into talking about surgery. So we're just cover very briefly what the national statistics are right now. Cover what types of operations there are out there for bariatric surgery. Talk a bit about outcomes. One thing I want to focus on is what, apart from weight loss, can bariatric surgery accomplish for patients, because I think that's kind of helpful in deciding who to refer for bariatric surgery. Talk a little bit about who's a candidate for surgery and what the process is to get a patient to surgery. And then for providers out there who may be seeing patients who've had bariatric surgery in their offices, how to recognize more common complications and how to manage these. So none of this is going to come as a surprise to you, but this is what has happened in the last 5 years with the obesity statistics. So the orange in 2011 being states with populations over 30 to 35% of people with self-reported obesity, and then 5 years later, the much more extensive orange that you see. Oops, sorry, that skipped way ahead. Sorry about that, a little jumpy. And then also, just so we know, and I'm sure all of you are well aware, currently, or as of 2016, 32% of the population of Iowa was in the obese range. I like to put this up here because I want to remind us of what we're fighting, that it's not the number on the scale, it's the relative risk that we're looking at when we're taking care of obese patients, what their health trajectory is and what we're trying to help them avoid and prevent. So this is the heart disease death rates in age 35 plus in the country, and I just kind of transposed it here with the obesity map. Obviously, incredibly well correlated. So about a third of patients who fall in the obese category of BMI over 30, about a third of them have severe or morbid obesity. And obesity is being linked to more and more diseases that we deal with on a daily basis. Type 2 diabetes is very clearly correlated. Heart disease, stroke, osteoarthritis, and cancer, things that we deal with on a daily basis. Cancer is a really sort of hot area of research in links to obesity. They're really starting to find some clear associations, especially with colorectal, prostate, endometrial, kidney cancer. Just a quick reminder, patients with morbid obesity have 50 to 100% increased risk of premature death compared to healthy weight individuals. And we're talking about longevity when we're deciding to treat somebody with an intervention like surgery. You're talking about their survival, and you really can improve survival after surgery. The reminder that median survival is decreased 2 to 4 years with individuals, for individuals with BMI of 30 to 35, and 8 to 10 years for people with a BMI over 40. We see these people every day, and I think this is just sort of a reminder of why interventions are needed. Fortunately, it doesn't take a huge amount of weight loss to make a big difference in relative risk, and I'll talk a little bit more about that. And then, of course, we're all aware of the economic costs. This is a 2011 statistic, $270 billion cost to the U.S. economy, and I'm sure at this point it's greater. So this is an older chart, but just a reminder, these are just for the class of obesity with a BMI over 30. The relative risk in men and women of heart disease is twofold, stroke 1.5 times, diabetes, 6 to 7 times the risk of the average population, and then cardiovascular mortality as the BMI gets higher, it's obviously increased. So apart from weight loss, what do we see after bariatric surgery? Actually, the results of resolution of comorbidities after bariatric surgery is much better than the weight loss. So are we creating a bunch of people with a BMI below 25? Not really, no. But we are really improving their life expectancy and their disease-free health. So heart disease, we see a 56% reduction in mortality from heart disease in patients who've had bariatric surgery. Diabetes is still one of the most improved diseases that we see after bariatric surgery. There's both a metabolic component to that and a weight loss component. We see 86% resolution or improvement and a 92% reduction in mortality from diabetic-related disease. There may be some people in the audience who are experts in sleep apnea, and the relationship between sleep quality and weight is being positively identified. And sleep apnea is a very responsive comorbidity to surgery. We did a small study in our own patients, just looking back at how many patients were off their CPAP at what point after surgery, and by 6 months, about 75% of patients who had been CPAP dependent were no longer using their CPAP and reported a far better quality of sleep. So very weight loss responsive and surgery responsive disease. Cancer, we see a 60% reduction in mortality from colon and breast cancer after bariatric surgery, and the premature death risk that we talked about earlier decreases by 30 to 40% in bariatric surgery patients. I don't know why I'm sorry, this skips around. So when we look at resolution or improvement, this is a study by a group of bariatric surgeons from the Cleveland Clinic who have a very well-run study called the Stampede Trial, comparing the best medically managed patients to a group of bariatric surgery patients with diabetes. And their markers in their patients after gastric bypass, and this is long-term, I think this is a 7-year outcome study, that 85% of the patients who had surgery had an A1C below 7%, blood pressure 63% were in range, and then 73% of their patients had their cholesterol parameters were were in range of the ADA guidelines. This is with the BMI, in the ranges of 35 to 42 or so. So it is separate from their weight loss. So obviously the better the weight loss, the more robust the effect, but still not being below a BMI of 35 isn't a good reason not to recommend an operation. And then these are just some of their heart disease risk reduction percentages here that I circled in blue. I just put this up here because, if this is one of your patients who's kind of has many or all of these comorbidities, we all kind of have a question of, is there a magic window when you're looking at someone's health trajectory where you think, that bariatric surgery might be the right thing for this patient? Only a small percentage of patients who are eligible for surgery are referred, and I think there's some little bit of outdated information out there. The risk of major complications for bariatric surgery, all bariatric surgery, is about 4%. Mortality risk is 0.1% from bariatric surgery. From getting your gallbladder out or getting your hip replaced is actually far higher than that. And the average weight loss results are about 50% of excess body weight is lost and maintained. So for all comers, all different kinds of bariatric surgery except for lap bands, and I'll talk a little bit about that, you can calculate for your patients what would be their average result after surgery. About 50% of excess body weight loss, kept off long-term, meaning about 10 years. Comorbid conditions actually exceed that 50% by, upwards of 40% in the case of diabetes, sleep apnea, and cardiovascular disease. So, like I said, think of it as a treatment for much other than weight loss. So, like I mentioned before, only about 0.05 of eligible patients are ever referred for surgery, and obviously we can't operate on 30% of the population. So still, you would think that we would see a lot bigger numbers than this. In 2016, 216,000 bariatric cases were performed in this country. And you can see it going up over the years. And some of that is because of the introduction and acceptance of sleeve gastrectomy, which is easier and faster, and some would argue safer than gastric bypass. So these are the numbers now of what's being, ratios of what's being done. So sleeve represents in the country about 60% of cases done, and gastric bypass is down to about 20%. Revisions, though, so conversion of another procedure or repeat operations, is up to 14%. And some of that is because of this huge increase in sleeve gastrectomy. People are needing second operations either for failure of weight loss or for reflux. So we were discussing earlier what might be some of the reasons why so few of the eligible patients are referred. And I think there is old information now about the risk and about the success rates out there. And also that, if you can't get your BMI below 25, what's the point of taking such a drastic measure? And I think we need to reframe our opinion about it being a drastic measure when we know what the long-term outcomes of remaining obese are. So things I want to share is that the operations are done differently than they were, 20 years ago. We do 100% laparoscopic operations at the university, both bypass and sleeve. 90% of the patients go home the following day. and the other 10% go home the day after. Usually we keep them over for nausea. That's the main reason for a second night stay. But the old problems with wounds and hernias and immobility, those are really things of the past. Our approach to the patient is much different. And being at the university, our focus is on education. So our patients go through a minimum three-month education process before surgery. This is a team effort, so there we have our dietitians, our specific psychologist who screens every patient. They have to go to teaching, they have to come to compliance. They have a binder that they carry with them, for the whole entire process where they're logging everything, from everything they eat to exercise, their supplements, etc. So, we realize that we provide a technical service that helps, but really the diet, exercise, lifestyle modifications that are required for weight loss are still required whether the patient has surgery or not. So I also think that there is some bias in the general public that, and even for patients themselves, that they think of weight as an individual's responsibility, that they don't think of it as a disease that they should get care for. So I think that self-referral may be inhibited by that. And there's some good surveys out there for why primary care providers may not refer patients who are eligible. And in these surveys, most of them cite futility as the number one reason for not addressing weight at clinic visits. And also, I think we all know people who've had bariatric surgery and not been successful. And I think, you might not see the major successes. They might not come back to your clinic, okay? Their lives are much different. So I think that selection bias for the people that are still struggling, that might be part of the reason why people might be reluctant to refer. So just to try to help, navigate when to refer somebody who you think might be at risk, to think of risk as a continuous concept that's based more than BMI, and that there should be a finite period of best medical management before it should trigger another intervention. 6 months is probably a good period of time to really, give it a great effort at diet, exercise, and lifestyle modification. And maybe if you're not seeing results, maybe time to consider if surgery would help the patient. So diabetes, hyperlipidemia, sleep apnea, and NASH are all diseases that are weight loss responsive. And so if you have a patient with a high BMI, in the 40s or above, and then you're also seeing these comorbidities, then that might start you thinking about would surgery be right for this patient. And he has a little diagram here, and it corresponds to what he's saying in the table here, that BMI over 40 with a serious weight loss responsive comorbidity, surgery referral is indicated, and then a BMI over 50. I mean, you can see the trajectory that somebody like that is on, and maybe surgery should be considered for that person. So these are the ADA guidelines for 2016, and to try to help navigate who might be a good person for referral is somebody that's doing everything that you're telling them to do. They're you've got them on maximum medications, but you're just not seeing the results that you think should be happening. Well, those people might be less responsive to medication, and something else might need to be considered. So what I would say is, if this is something that you're trying to figure out in your own practice, that there are lots of risk assessment calculators online. There are some bariatric surgery calculators online, risks with and without surgery. This is just an example that I plugged in, several years ago just to see. This is one of our patients. He was a male. This is a AHA, heart disease and diabetes website. So he was 35, so he was a young guy, 6'1", didn't have any pre-existing conditions except that he had had diabetes diagnosed 2 years before. And when he was diagnosed, his hemoglobin A1C was, off the chart. It was 12 already when he was 33 years old. He weighed 322 pounds. I think I calculated it here. It put his BMI at 42.5. He had a construction job, but he rated his physical activity low. He did not smoke. His these are his vital signs from his initial visit. So his blood pressure was high, total cholesterol was high, HDL was low. So this 35-year-old man had a 10-year risk of 70% of having a heart attack, 6% risk in 10 years of having a stroke with the numbers that we met him with. And then I put in his number. He was late for his 6-month visit, so I put in he actually came to see us 9 months post-op, and I just put his numbers back in, and he was off all of his medications for diabetes. He was 6.7 was his hemoglobin A1C. So not perfect, but still low risk. Blood pressure was a little bit high. He had a great response to his cholesterol numbers. But look what it did for his heart attack risk. 10-year heart attack risk went from 70% to 5%. So I think, obviously I'm a broken record about this is about risk. This is about longevity. This is about, health trajectory when you're figuring out who should think about surgery. I'll just switch gears a little bit to talk about what procedures are available out there. The gastric band has limited use at this point. Really, the results didn't wind up being as fantastic as the companies who made the band made it seem. Really, long-term weight loss was around the 20% range, and we don't put bands in. I think, in the last 10 years or so, when I first got to the university, they'd put 10 bands in, and really they didn't put any more than that since I got there. We take a lot of them out and convert people to either sleeve or gastric bypass now. And the other procedures that we do are gastric bypass and sleeve gastrectomy. I showed you the national averages earlier, but I think that would probably be inclusive of all non-academic medical centers. We tend to be in the almost 50-50 range for gastric bypass and sleeve gastrectomy, and I think that's just a reflection of our comorbidities and also patients coming to us for gastric bypass because it's not being done in as many places as it used to be. It's been replaced by the sleeve. So we still sit around 50-50. I would say that we have some pretty strict indications for gastric bypass. Anyone with refractory reflux should not have a sleeve gastrectomy unless there's some reason why they can't have a gastric bypass. You have a pretty good chance of making their reflux worse after sleeve gastrectomy. And their motility may also be abnormal, so we work that up as well. Any kind of dysmotility is also a relative contraindication to sleeve gastrectomy. We do use a calculator for patients with diabetes. Severe diabetics who've been on insulin for a number of years and who've had the diagnosis for a number of years, they actually have similar resolution rates, sleeve and bypass, and so I generally leave it up to the patient, and so we're doing more sleeves for diabetics than we used to. It used to be felt that the most robust hormonal effects were from gastric bypass, but when you look at the risk later in the stage of diabetes, then the results become equivocal. You may see patients who've had a duodenal switch or biliopancreatic diversion at other places. I don't know of anywhere in the state of Iowa that does this. These are folks that need very close nutritional monitoring for vitamin deficiencies. These are only done really in certain centers of the country. Now, the resolution of diabetes and durability of weight loss for these patients is fantastic. So these patients can be referred out to some of these centers if you feel like they need something more than a Roux-en-Y gastric bypass. There is a new procedure that is sort of a second option for patients who've had sleeves but either have failure of weight loss or fail to resolve their diabetes, and that's called a SADI or SIPS. It's basically bringing up a loop of duodenum to the post-pyloric, a loop of jejunum to the post-pyloric duodenum, and it has similar results to biliary-pancreatic diversion as far as weight loss and resolution diabetes, but improvement in vitamin and mineral deficiencies and diarrhea, which is another disadvantage of duodenal switch. So there are still only certain centers in the country that are doing this, but as we do more sleeve gastrectomy in the country, there's going to be more patients that need a second procedure. And so those of us that do revisional surgery are probably going to be learning to do this and offering it, myself included. Just for those of you that aren't familiar with the anatomy, the top picture, I guess top right picture is gastric bypass. We make a small pouch out of the top portion of the stomach. We bring up a limb of small intestine that measures anywhere from 75 to 100 centimeters, and we bypass that first portion of stomach and duodenum. And then the second picture is gastric band. Letter C is a gastric sleeve, and then the last picture is that biliary-pancreatic diversion. This is just a picture of the SADI. This is just what I mentioned about the lap band long-term outcomes not being so great. Basically, percent excess weight loss after 18 years range in the 27%. So that's only about 10% of total weight loss, which with strict diet, exercise, lifestyle modification, and pharmacology, you can get about those results without an operation. Sleeve and gastric bypass outcomes in general. The lowest weight we see for sleeve is usually by 9 months, and then for gastric bypass is about 12 months. Gastric bypass has a little bit longer length of time that patients lose weight, up to 18 months in women. And sleeve usually is well tapered off by the 1 year mark. You can mathematically predict what patients' end weight will be based on how they do in the first 3 months. So they're really carefully monitored, and any sort of indication that there may be plateaus or behaviors that might need to be looked at, we start monitoring them and following them more closely. Preoperative BMI, sleep apnea, and diabetes are predictive of less than 50% excess body weight lost after 5 years. And there is approximately 40% failure rate by the standard definition of greater than 50% of excess body weight lost. And just to reiterate, that doesn't follow for the resolution of comorbidities. This is one of the longer studies that we have out there for sleeve gastrectomy. This has really only been accepted and done in large numbers for less than 5 years, so we don't really even have great 5-year data yet, and we certainly don't have good 10-year data. And I tell patients that when they're deciding what to do, because we have that data for gastric bypass. And so this is a bariatric surgeon from Australia, and his group always has really good results. They've got, at 11 years, 62.5% excess body weight lost and kept off. That's, above the average of 50% nationally. And let's see, they had a 32% reoperation rate in this group, and about 80% of those were for failure of weight loss, failure to get that 50% excess weight or more. And then about 20% were for reflux symptoms that were so bad that the patients had to have an operation done to relieve them. And in general, it's accepted that those patients get converted to a gastric bypass, which is a low pressure system and likely to improve or eliminate reflux symptoms. So here's a 12-year study for gastric bypass. This one it's a little bit different as far as how they determine their weight loss. They had a 27% total body weight loss kept off. It's equivalent to the 50-60% excess body weight loss. But their resolutions for diabetes over 12 years, 50% of their patients were on no medications at 12 years. Satisfaction rates are better with bypass than sleeve. I've found that sort of anecdotally in the clinic that people who have bypass are they just seem to be more satisfied with their operation. Their results are more consistent. I think that I started to see last year a kind of an increase in patients requesting a gastric bypass because they knew somebody who had a gastric bypass, they knew somebody who had a sleeve, and the gastric bypass patient did better. So there's not a huge statistical difference between the weight loss in sleeve and bypass. And there's obviously, and there is increased risk with a gastric bypass of certain complications that don't exist with a sleeve. But overall, I think we may be seeing a shift of an increase in gastric bypass in the next few years. So we also have to treat this as a chronic disease as surgeons. We have to help patients decide if they should have a second time operation. And we also have to get together with all the resources we can find with our medical colleagues, our endocrinologists, our psychologists. So when we start seeing people either regain weight or start to see hemoglobin A1Cs climb, it really is a team effort to try to figure out how to approach these patients. And I know that these are the patients that, you know, those of you that are in primary care see patients who they haven't seen their surgeon in 3 or 4 years because they've regained weight. And what should you do with these patients? And I'll talk a little bit about that. So this is just a consensus about who is a candidate for bariatric surgery. It used to be that the only comorbidities that qualified a person was diabetes, high blood pressure, and sleep apnea. But this big list at the bottom, BMI over 35, and any of these comorbidities is generally covered by most insurance companies now. So it's really expanded who is covered for bariatric surgery, much more so than even 10 years ago, just to keep that in mind. And this is actually similar to the Medicare list, which they are the most strict. So there's more comorbidities than just those 3 that we think of. We don't have an age limit in our program. The oldest person that I've operated on was a very young 72. Medicare used to put an age limit on who could have surgery. That doesn't exist anymore. BMI limit, that's definitely a technical consideration for us, is will we be able to maneuver in the abdomen? Is the patient healthy enough to have surgery? And that's very individualized. I would say in general, high 60s is probably the heaviest person that we operate on, but we help people get there with our dietary program and medications also. And then, of course, they have to be medically fit enough for surgery, and we help make that happen too when patients come to us. Contraindications, any active drug or alcohol problem, including any sort of treatment, inpatient or outpatient, within 2 years of applying to the program. And that's not just us, that's a sort of a universal recommendation. Severe cognitive impairment it's very difficult to say no to somebody, that because they're not able to follow an eating plan and things like that. We try very hard, but there is a certain level of, of intellect that it takes to kind of get through the compliance process and get through the surgery. And so that's sort of a judgment for us. Any active psychiatric problem that is not well controlled or untreated eating disorder. And this is a hard one because there are several people, or there's a large portion of people with binge eating habits, but not necessarily binge eating disorder. So our psychologist helps very much to screen people for anything that might need to be treated before surgery. The others are kind of, common sense. Weight gain during the compliance process is something that, we try to limit to 5 pounds or less. We prefer people to lose weight while they're in the compliance process, but we have seen refusals from insurance if there is weight gain during the compliance process. So those people are just mandated to more dietary compliance. So if you refer a patient to us, they fill out an application with their health history, and they are evaluated. We make sure that they have benefits for bariatric surgery. They go through a minimum of 3-month compliance program. Some insurance companies require as much as 12 months, which there's a serious dropout rate when you extend it that long. We don't have a strict weight loss requirement unless there's some technical consideration. If they have a very large liver, for example, then they may need to lose more weight before surgery because it just gets in the way of getting the operation done safely. Everybody gets a psychological assessment. They get insurance approval after all of that's complete, and then they have surgery. We see them at 1 week, 1 month, 3 months, 6 months, and then every year for lifetime if they'll be there. We get about, after the first year, our follow-up drops off to about 50%. And we work really hard to contact everybody, but that's about where we stand. So this is because I think I was asked to sort of say some of the dietary components of the program. They are on a very low-calorie blended diet for 10 to 14 days before surgery. That's to shrink the liver and reduce the intra-abdominal fat. It's purely technical. It's not a test. Our procedure length's probably longer than in private practice. We're training a fellow. Sleeve gastrectomy takes about an hour, and gastric bypass takes about 2.5 hours. That's because of the suturing involved and teaching somebody how to do that suturing. I think if I did it by myself, probably 1.5 hours. So our laparoscopic rates for primary procedures is 100%. In some referred patients who have bad complications and abscesses and leaks, etc., we have to do open surgery to reconstruct them. We don't do that very often, maybe a few times a year. Otherwise, we try to do everything laparoscopically, including converting people from sleeve to bypass or band to bypass. So we talked a little bit about this. How long will people have to be off? 2 to 4 weeks. We do put them on a lifting restriction, but we encourage physical activity. They should follow up with their primary care doctor within 2 weeks postoperatively. And then we start checking their nutrition and beginning their supplements at 1 week postoperatively. This is the regimen that both sleeve and bypass patients are on. It's really not, anything dramatic. It's to try to prevent deficiencies, not necessarily that we see them all the time, because we want people to be maintaining this. And it has been shown that actually sleeve patients need this same regimen during the first year because they just don't get the dietary complement that they need. So both types of surgery require this for the first year. This is something that I put in here in case you need a reference for, for the future of what to look for. What are the preoperative and postoperative deficiencies of some of the major vitamins and nutrients, and how would you supplement those in case you're seeing post-bariatric surgery patients who've been lost to follow-up in your clinics. B12 and thiamine deficiencies are things that we are try to be very vigilant about monitoring for. So any kind of neuropathic symptoms, even like foggy brain type symptoms, we make sure that we're checking their B12 and B1 levels. Iron, same thing if people complain of lightheadedness, weakness. These are all things that are, normally absorbed in the proximal small intestine, and when you bypass that or you increase the emptying rate like you do with a sleeve, then it's not absorbed as well as in the native state. We monitor calcium and vitamin D levels. So how we follow people when we first meet them, we get baseline of all of these things, and then at 1 week we check their hemoglobin and their B12 and their prealbumin. And we do that for their 1 month, 3 month, and then we check their hemoglobin A1C and their lipids at 3 months. And then you see the 6 month and annual labs after that. And this is something that if you want to refer to these slides for if you have patients, I did that. This is the program that we use for our patients. We call it the bubble diet. It's filling in bubbles instead of counting calories or macros. And I think because patients eat the same meals very often, they once they've done this a couple of days and they choose their foods from these ADA books, they find it very easy, and people are pretty successful with this as their diet plan. So things that I wanted to just briefly cover in case you happen to see these and want to know what to do if you see them. A leak you likely won't see in anything but an acute situation. You should suspect if the patient's had recent surgery, they have persistent abdominal pain, tachycardia, pain out of proportion of a normal postoperative state, high white count. That surgeon needs to be contacted right away. For gastric bypass patients, things to look out for. The patient comes to you, complains about epigastric pain, regurgitation, vomiting, evidence of GI bleed. Think marginal ulcer, stricture, or gastritis, pouchitis. None of our patients are to take any sort of NSAID, and they are asked not to smoke at all. So we nicotine test them before surgery. We're very strict about that. A huge portion of marginal ulcer and stricture can be traced back to smoking in gastric bypass patients. So regular kind of run-of-the-mill reflux after bariatric surgery can happen and should be treated like it is with any patient. But if it's refractory to medical treatment, then that patient should get a consultation with a bariatric surgeon. Any abdominal pain seen either in the office or in the ER that's persistent and concerning should include CT imaging to rule out internal hernia or bowel obstruction. These are things that, while they may not need urgent surgery in the normal patient, anyone post-gastric bypass likely will need surgery to fix this problem. There just isn't room in the system to decompress it, and so it usually requires surgery to lyse adhesions. We still do it laparoscopically. Usually they go home within 1 to 2 days. You may see patients who've had gastric bypass some time ago complain of lightheadedness, shakiness that improves when eating a high carbohydrate snack, which is like they go to candy, things like that. This can precipitate dumping, so that just worsens their symptoms. This is usually something that's just a deviation from the diet they should be on, which concentrates on getting a steady state of protein and then having low sugar carbohydrates as their carbohydrate. So it usually just requires a dietary modification to fix it. There can be a more serious condition called insidioblastosis that should have endocrine consultation. It's usually still managed with dietary modification, but it's something to be aware of. I want to make sure that I allow time for questions. So I would say if you do see patients who are plateauing in the early stage, they should be seen by surgery right away. They need re-education. Same thing with weight regain. We have started using pharmacology, newer weight loss medications in the clinic. Patients who've had bariatric surgery actually respond better to weight loss medications than patients who haven't. What the reasons for that are sort of subjective research at the moment. So we just to conclude, we talked about bariatric surgery being the most effective treatment for obesity and related metabolic disease. Long-term results are about 50% of excess body weight is lost and kept off. Better than that for diabetes and cardiac risk factors, also significantly decreased risk in common cancers. We have a little bit of a gray area for who to refer and what the reasons for that might be, and hopefully this has helped kind of help you navigate, who might really benefit from having bariatric surgery. And I'll open up for questions. Anything. It doesn't even have to be related to the slides. If there's anything you want to know about surgery.
Thank you. So I'm always, in primary care, always preaching about diet, exercise, and lifestyle changes, and have been discouraged about medications or any medications that you know of shown to have long-term improvement with the weight loss, mortality, morbidity, or is it? And then do you restrict your acceptance of patients if they haven't had medication trials?
To answer your last question, no. Most of the patients we see have not been on medication, and we use it in the either post-operative patient who has either regained weight or has plateaued, or in patients who we need to get weight off of to safely do surgery. What has been kind of become recognized is that all the medications that are out there are lifelong medications, that as soon as they're discontinued, people tend to regain the weight. And so that's something that, you need to address with the patient. And also, even when they may stop working and you have to transition to a different one. So it's kind of a newer area of expertise, basically. We have a bariatrician who's an endocrinologist who did a fellowship at Cornell with the folks that kind of use these medications this way, and we brought him onto the team because this isn't our area of expertise, and so I would say just knowing that they may stop working and you'll need to switch to another one, and that you're talking about a lifetime of medication, and the affordability is a big factor. So phentermine, slow release tend to be covered by insurance. There are kind of coupons and programs for the other ones. The one we use the most frequently that seems to have the best results is Contrave. And you can get kind of a generic combo, but the dose of naltrexone is a little bit different. So you just have to kind of try it and see. Sir.
Is there a subset of patients that you see prior to surgery, such as those who might lose more weight in the first 3 months, who are more likely to keep it off 5, 10, 15 years down the line?
So let me rephrase, and you tell me if I'm rephrasing correctly. Do people who seem to do really well preoperatively sustain that? Yeah, they do. I think there's an element of buy-in that predicts success. So the people who become very enthusiastic about the way they're feeling, about their exercise, about that they're following their plan, that they kind of changed their life before surgery, those people do better.
Now, you mentioned 50% of people are unsuccessful losing the ideal weight loss. And those subset of patients who, quote unquote, buy in before, do you know what their percentage of success 5-10 years down the line is?
So I guess the only sort of data in the literature to say one way or the other are the preoperative comorbidities that you're looking at. So the best predictor of getting a patient's BMI below 30 with bariatric surgery is to have the BMI start below 40. And then diabetes, sleep apnea, and I can't remember the third one, but those are predictive of getting in the lower percentages of the weight loss. So that's when we start talking about, well, is there kind of a magic window that, we can capture for some patients?
Yeah, the education and compliance period of time, you say it's 3, 6, 9, and 12 months. I mean, is there evidence that the outcomes are different at 3, 6, 9, or 12 months? It seems like at 12 months that might be a barrier to people actually.
I agree completely, and that's insurance determined. So there's I can't remember what the company is, but there's one company that we've seen a few people, and they have a 12-month requirement. And yeah, the dropout from that is incredible. The reason I've had all of our patients just mandated to 3-month period, even though Blue Cross Blue Shield doesn't require that, is that it takes 3 months to form a habit. And I want them to be able to have those in place for afterward. And I just think being in a hurry is just not the way to approach this. Although people want their surgery tomorrow, there's a lot to learn for success. And, I would say the technical service we provide is 25% of it, and 75% of it has to come from the patient. And so that's kind of been my, policy of waiting until that 3-month habit is formed. Now, I think some other programs don't necessarily require that.
I have heard about some new endoscopic revision procedures. Can you speak about any of those?
If I know what you're referring to, there's sort of pouch reduction and anastomotic reduction. I would say that those are no better than the best, medication and types of things. So it's also true that anastomosis size does not make a difference with weight loss. So whether you have a 3-centimeter anastomosis or a 0.5 centimeter anastomosis, people lose the same amount of weight. So trying to downsize these things, and same with pouch size, trying to downsize these things, I think, first of all, insurance doesn't pay for it. So you're taking, $10,000 out of someone's pocket for something that doesn't really work. So far, I haven't been impressed, and I think most surgeons are not a proponent of that. All right, thank you.